There's truly nothing like a sick bradycardia patient to humble you. Kingsley here, your ultrasound trained board certified emergency medicine doc, and let's talk about some bradycardia. Now, when it comes to bradycardia, the first thing I'm getting is that EKG. So typically bradycardia is going to be a heart rate less than about 60 beats per minute. When I get that EKG, I'm asking, is this sinus or is there some type of block? First question. Second, I'm asking, is there some reversible cause for this? Lastly, I'm asking, is this person showing signs of confusion, hypoperfusion, or are they going to benefit from actually being paced? So that's more so of the stability component. So when it comes to getting that EKG, I'm looking for a couple things. Is there signs of hyperkalemia on the EKG? Or is there a wide QRS complex? Are there peak T waves? And then I'm asking myself, is this sinus bradycardia? So I'm going to look for those reversible causes, or there possibly a block. Now, when it comes to a first degree block, that means that PR interval is greater than 200 milliseconds, or 4 little boxes. When it comes to that second degree, we're going to have two types. We're going to have second degree type 1. This is going to be typically when we have that widened PR interval greater than 200 milliseconds. But then occasionally we're just going to drop our QRS complex randomly. You can have a second degree type 2, also known as Wenckebach or Mobius type 2, where essentially you're going to have this wide PR interval greater than 200 milliseconds, and it's going to keep widening and widening until eventually you drop a QRS complex. Then lastly, we're going to have our third degree block, which is basically a complete block where there's total disassociation between atrium and the ventricle, meaning that the space between P waves is perfectly the same, and the space between QRS complexes is perfectly the same, but they're not talking to each other. So you're going to have that wide QRS complex that is having regular intervals that's totally disassociated from the P wave. Now, when it comes to treatment, you can use 1 milligram of atropine to help with that bradycardia. Typically, this isn't really effective as we get to higher levels of blockages. Like a third degree complete heart block is really not going to be that susceptible to atropine. So when we're thinking about these possible courses, we're thinking about things like beta blockers, we're thinking about calcium channel blockers, hyperkalemia, we're thinking about this person possibly hypothermic or hypothyroid. So really trying to treat the underlying cause. In the conversation of stability, and that heart rate's causing them to be hyperperfused, we could transcutaneously pace, right? So putting those pacers on the patient and giving them some analgesia because we're not mean people. And sometimes we don't get great capture with transcutaneous pacing, and sometimes we need to actually go intravascular, right? So we need to do something like a TVP or transvenous pacing. So when it comes to like just overall evaluation and kind of thinking about the bradycardia patient, you want to get that EKG first. See if you see anything obvious on that EKG as a possible reason for them being bradycardic. You want to see, is it sinus or is there a block? Now, if there's a block, determine the degree and figure out if there's something that we can reverse and get this patient ultimately to a cardiologist, because some patients will need a pacemaker and an AICD. By no means is this video the all-encompassing video for bradycardia. It's just not possible, but hopefully this gives you some good foundational information.